Good morning, or good afternoon in some cases, and welcome to Empowered Relief, a one-session pain relief skills intervention featuring Dr. Beth Darnell. I am Melissa Bombeck, the FPA CEO and your moderator today. Dr. Darnell is a professor at Stanford University School of Medicine and director of the Stanford Pain Relief Innovations Lab. She is also a member of the FPA Medical Advisory Board. Thank you for joining us today, Dr. Darnell. Before we get started, I'll ask that attendees submit questions using the Q&A feature on your screen. We'll get to as many as we can after the talk. And now I'll turn it over to Dr. Darnell.
So much, Melissa, and I'm just so delighted to be with all of you today and to share with you some of the work that we're doing. These are my disclosures. My research is funded by the National Institutes of Health and also the Patient-Centered Outcomes Research Institute. And what I'm going to be focusing on today is broad integration of evidence-based behavioral pain treatment. And I've been really focusing on this from the perspective of empowered relief. There's just really a vast need for scalable, accessible pain treatments, as we know that very few people have access to non-pharmacologic and evidence-based treatments. What these treatments allow for is broad symptom management. They allow people to have quicker and more comfortable recovery after injury or surgery. They can help the millions of individuals who are living with ongoing pain, including, of course, chronic facial pain, and also in some cases can help people need less pain medication. So all of you are well aware of the problem of pain in America. Up to 1 in 3 adults are living with ongoing pain of some type. And you know that this confers tremendous suffering to the individual, to the family, and also to the community. For the past decade, there have been federal institutes and agencies that have really called for a shift in how we treat pain, a shift away from a purely biomedical approach, and a call for us to better integrate what we call behavioral strategies, psychological strategies, self-management strategies. These terms are sometimes used interchangeably. But what they're calling for ultimately is whole person pain care. So we're not just focusing on the localized site where an individual experiences their pain or where there is an issue in the body, but that we're addressing the needs of the whole person, and importantly, equipping individuals with an effective skill set so that we can best regulate our mind, our body, and our actual experience of pain, the way that pain impacts us. So despite all of these calls for this integrated whole person approach, what we've seen is that we've failed to deliver on these calls. And there are many reasons why we find that we're falling short of this national goal. It still remains that if a person goes to a physician for treatment of pain, in this case, this is an illustration of back pain, but of course, facial pain as well, that there will be usually a very good workup on a person to try and get to the cause of the pain. And this is important. This is absolutely needed. We need a biomedical approach. But if we only apply a biomedical approach, then we're failing to address the full understanding of what pain is. Pain is processed in the brain and the spinal cord, regardless of the locality of the pain that we experience, regardless of the cause of the pain or the etiology of the pain, regardless of the diagnosis that we carry. All pain is processed in the central nervous system, the brain, and the spinal cord. And for this reason, our brain and our spinal cord, the central nervous system, has the capacity to either amplify some of the pain processing, or we have the capacity to dampen some pain processing. This is what we call self-regulation of pain, and it can provide people with a crucial skill set to be able to modulate the distress that pain naturally causes us. So we all experience pain, but once we have ongoing pain, it can be so very distressing. Pain is a biological hardwired cue. It really implores us to escape whatever is causing the pain. And it's an important survival cue. If I place my hand on a hot stove, I don't even have to think about what I'm going to do. I'm immediately going to withdraw my hand. Again, it's hardwired in our neurobiology, this desire and the impetus to escape pain and to protect ourselves from further damage. So pain registers as our harm alarm, this signal that there's something in the environment that's a threat, that's dangerous, that we need to escape and protect ourselves from harm. But once we have ongoing pain, whether it's facial pain or another diagnosis, fibromyalgia, it could be any type of pain condition, we can't readily escape that pain. We can't pull our hand away or run away from whatever is causing the pain. And yet still, that harm alarm is ringing very loudly, imploring us to escape whatever is causing it. It's no wonder that pain is so distressing when we're biologically hardwired to escape something and we simply can't act on that in a meaningful or productive way. So that's very distressing. It can be confusing. We want to be able to successfully act on these impulses, and we cannot. So when we have ongoing pain, this is a common experience for people. Here, this gentleman is saying, there's nothing I can do about my pain. I know it's only going to get worse. When we're unable to successfully reduce our pain, it can lead us to feel helpless and hopeless about our pain. And so we're all born with the motivation to escape pain, but we are not born with the understanding of how to modulate pain and the distress that it causes us. This must be learned. This is the realm of pain psychology, behavioral medicine, where we can, with individually or in a group setting with a trained instructor or professional, we can learn the information and skills to help us have better control over our experience. Now, the best studied behavioral treatment for chronic pain is called cognitive behavioral treatment or cognitive behavioral therapy for chronic pain. And so again, this can be delivered one-on-one or typically in small group format, where over the course of about 8 weeks, it can be 8, 10, or 12 sessions lasting 2 hours each. People learn various information. There are topics covered and skills that are acquired by the people, by learners. And so this is just a listing of some of those topics. And so this is a pretty standard curriculum for CBT for chronic pain. There's about 30 years of evidence behind this treatment modality. And so this is not about putting on rose-colored glasses and denying that pain exists. This woman may be having a really bad pain day. And so she can say, you know, my pain's bad today, and there are several things I can do right now to soothe myself and feel better. So I'm going to start this video over again so I can stage this a little bit better. So what we know is that when we steer our neurobiology away from the distressing elements, when we have better regulation of what's happening in the central nervous system, we can see those changes happening in real time. So this video is fMRI video, or functional magnetic resonance imaging. What it's showing is, and I'll show it to you in just a moment, I'll move to that slide, but what the video is showing is a person focusing on their pain and feeling helpless about it. And then on the other side of the slide, they are applying some of these skills that help people calm the nervous system. And you can see the difference, what's happening in the brain in real time. So unhelpful thoughts about pain, we see an amplification of pain processing. And then when a person is applying effective self-regulatory skills, we see that it confers pain relief that is evidenced by reduced pain processing in these brain images. Now, that's all very cool, but we're not interested in just helping people have pain relief in a scanner in those artificial environments. What we want is to help people gain lasting relief. And this is where regular skills use comes in. And so it's not enough to just learn these skills or to use them every once in a while. What we see is that people get lasting relief, symptom reduction, when people engage with these skills on a regular basis over the course of a couple of months. So we see that these regular skills use, it dampens pain processing, it helps reduce the physiological hyperarousal that naturally occurs when we have ongoing pain. We start to entrain positive neural patterns so that our mind is both less attuned to pain and less responsive to it when it occurs. This is where we gain that degree of control over pain processing because we can enact what we call a parasympathetic response, which counters this natural pain response that all humans experience, particularly when pain is severe and very stressful. So I just want to highlight this one study here on the bottom of the slide. These researchers scanned the brains of individuals with chronic low back pain at baseline, and then everyone went through an 11-week course of CBT, so 22 hours total, and then they scanned their brains at the end of treatment 11 weeks later. And what they found was that pre-treatment, people had evidenced volumetric deficits in key regions of the brain associated with pain control. And then using the skills and applying the information, 11 weeks later, they scanned their brains and they showed substantial volumetric increases in those same regions of the brain associated with pain control. And what was interesting was that those brain changes, literally structural brain changes, changing the volume of certain regions of the brain, this correlated with people's report of reduced pain intensity. And most interesting to me was that the researchers found that these changes in brain structure and functioning were entirely mediated by people's ability to control their cognitive and emotional responses to pain. So what does that mean? Well, what I'm talking about is the extent to which our mind is attuned to pain, whether we're ruminating on pain, and the extent to which we can go into some of those self-soothing actions that calm the nervous system. If we can learn that skill set and apply that skill set, what this study shows is that it both changes the functioning of the brain and also the very structure of the brain in less than 3 months' time. And that's a crucial point because people will always ask me, well, how long does it take for this, to see these results? And that's, this study is nicely illustrating. It does take a couple of months' time. Now, do we know exactly how much time? Maybe people would have evidenced benefits in 4 weeks' time, so we don't know. We just know that they scanned at the end of treatment. So I tell people pretty reliably, when you engage with this type of behavioral treatment, focus on using those skills regularly and give it a solid 3 months. You may notice benefits much sooner. But still, what the data tells us is that that results unfold over the course of a few months. So the evidence for this approach, it's low risk, non-pharmacologic, empowering to individuals. the data has been so strong that this one Lancet expert review panel recommended that pain education and pain CBT be offered as first-line treatment. Now, in this case, this is for back pain, but actually other societies have adopted this notion that these low-risk treatments that empower people should be applied at the outset of pain care. And, you know, we can all sit back and sort of laugh to some extent, because we know that nobody gets these treatments right off the bat. And in fact, many people never have access to these treatments, which is really unfortunate. And that's what we're trying to address with our work. In 2016, colleagues and I published a study that really tried to quantify what are these barriers? Why don't we have everyone having easy access to this type of care? It's not meant to replace medical treatments. Really, these treatments work alongside medical care. And what we see is that the treatments themselves can be burdensome because they're multi-session. We also see that people have problems with co-payments, or they're just not convenient. People have to work and they have obligations, and so they're not able to access the treatments. A big issue is that we do not have enough trained therapists or clinicians to deliver the treatments. And when it comes to patients who are undergoing surgery, we see that the people need asynchronous or more on-demand treatment options. So all of these barriers and the recognition that everybody should have access to this treatment approach if they so desire to have it, that was the impetus for me to develop Empowered Relief as a one-session intervention that rapidly equips individuals with effective pain relief skills. So think of it as taking those longer course treatments that are shown to work and compressing that down into a single session and packaging it in such a way that would be more acceptable to patients and ideally destigmatizing. So even the name of the intervention, Empowered Relief, it's meant to be more welcoming to people who may be resistant to certain approaches, treatment approaches. So what is Empowered Relief? It's a single session intervention, so 2 hours in duration. It is meant to be delivered to groups of people, patients, and their families, if family members would like to join in. So because it's didactic, this is not therapy, it is a didactic session, and so large group sizes are possible. The largest group that I have treated was 85 people at once in 2 hours. So over the course of 2 hours, people learn information about pain neuroscience. You go through experiential exercises. People learn 3 core pain management skills. And then along the way, people develop their own plan for Empowered Relief. So it's never enough to just learn information. Things change when we apply that information to ourselves and then engage with it on a regular basis. And so people leave the 2-hour Empowered Relief session with a completed, personalized plan so that they have their own roadmap for how to implement this information in their lives. Everyone receives a binaural app. So this is a free app that people download onto their phone or whatever device. And we have published data from 4 randomized trials, and I'm just briefly going to review the evidence for Empowered Relief for you. So our first study published in JAMA Network Open in August of 2021. And this was an NIH-funded study. This was conducted in people with chronic low back pain, but half of the sample that we enrolled had 2 or more pain conditions, chronic pain conditions, and about 1/3 of the sample had 3 or more chronic pain conditions. It's just that everybody who was involved had chronic low back pain as one of their pain conditions. And so people were randomized to one of three conditions. They were randomized either to 2-hour empowered relief, or they were randomized to a 2-hour back pain education session, no pain management skills. So we're trying to control for this, how much does this skills-based intervention make a difference? And then we compared also, people were randomized to a third group, which was the 8-session cognitive behavioral therapy, that's 16 hours, longer course treatment that is considered the gold standard for behavioral pain care. And we hypothesized that 2-hour empowered relief would be non-inferior to 8-session CBT, the 16-hour version. So this was a pretty high bar for us, hypothesizing that 2 hours might be comparably effective as 16 hours 3 months after the treatment was received. So we're really looking 3 months later, and we want to be able to show that these are comparably effective. And if we could show that, that would tell us that maybe, while we're still going to need longer course treatments like 8-session CBT, it might help us understand that scaling out a brief treatment could give people meaningful access to evidence-based pain care. And so fortunately, that is, our hypotheses were met. We found that 3 months post-treatment, empowered relief was similar to 8-session CBT for reducing pain intensity, pain interference, pain catastrophizing, which is basically an index of distress, pain-related distress, as well as it comparably improved self-efficacy for pain. It reduced pain bothersomeness, sleep disturbance, depression, anxiety, and fatigue. So we really saw these multi-dimensional benefits for this one-time 2-hour class when we followed up with people 3 months later. So in 2019, the US Department of Health and Human Services cited empowered relief as being a promising, scalable intervention that might meet the needs of a population of individuals, that we could conceptualize, that we could better meet the needs of 100 million Americans if we had something low cost, low burden, easy to receive, and if that were made more accessible to people. But this study was our first evidence that it was actually operating as we hoped it would. So we next wanted to know what happens if people receive empowered relief online. This was a study that we conducted during COVID. So large groups of individuals received empowered relief over Zoom. And this was a study led by Dr. Mesa Ziadny. And for this study, we enrolled people with any type of chronic pain. It wasn't just back pain, it was any type of chronic pain, people receiving pain care in the pain clinic. And we randomized people either to usual care in the pain clinic or to online empowered relief. There were no in-person visits. And as an index of people's interest in receiving home-based online behavioral pain care, we enrolled 100 people in the first 11 days that this study was open. And then we compared our two treatment arms, online empowered relief to usual care 3 months later, to see what kind of benefits people would get from empowered relief. And what we found was a similar pattern of results 3 months later. We found that people had reductions for pain intensity, anxiety, pain catastrophizing, pain bothersomeness, anger, and sleep disturbance, with our effect sizes being moderate to large effect sizes. So clinically important symptom reduction across a range of symptoms. And this is important. I think when people hear about behavioral treatments or psychological treatments, people will think, well, how is that really going to help me? Or people might think, well, okay, that'll help me cope with my pain. It'll help with my quality of life, but it's not necessarily going to reduce my pain. But what we're seeing across our studies is that we are reducing pain proper. So yes, there is this multi-dimensional symptom reduction, and certainly people have improvements in coping. But I invite people to conceptualize this as a primary pain treatment, because we have been seeing uniformly reductions in pain intensity and pain interference, not just in pain coping. So what we've been doing for the last couple of years is certifying clinicians internationally to become skilled and trained so that they can deliver empowered relief in their patient populations and their institutions and organizations. So to date, we've certified 800 clinicians in 25 countries. It's being delivered in 7 languages, and it's been received by more than 10,000 people with chronic pain. These are just some of the organizations that have empowered relief embedded into care pathways. It is being offered as standard care in all of these organizations you see on this slide. So what does that mean? What does standard care mean? It means that we are not singling people out based on a certain symptom profile. It means that if anybody, let's take Cleveland Clinic as an example, anybody going to Cleveland Clinic for spine surgery will be offered empowered relief as part of their spine surgical care. So it's baked in, the same in their chronic pain clinic and all of these other organizations that you see listed on the right-hand slide. They're offering it to everybody as pain care, not as alternative pain care, not as complementary, but just a primary pain treatment. And so that's really lovely, because it really honors that integrated approach. And what I especially like about it is that it destigmatizes this approach as simply being an important aspect of pain care. I think one of the big problems with how we have approached behavioral treatments or psychological treatments is that clinicians may apply screening measures and only offer these treatments to patients who have severe symptoms, severe depression or severe distress. And so then what can happen is that people will feel singled out. They may feel like, well, there's something wrong with me. You think my pain is psychological. It's all in my head. These types of experiences can confer stigma to individuals. And what we're trying to do is just normalize this as part of basic pain care, that everybody should have access to this approach if they would like to receive it. So we're conducting a national trial now. This is funded by the Patient-Centered Outcomes Research Institute, or PCORI. This is the PROGRESS study. This is a 6-site trial in which we are comparing online delivered empowered relief. We're comparing it to online delivered 8-session CBT for any type of pain. So if you have facial pain, you can come into our trial. The only stipulation is that you have to be receiving pain care at one of our 6 study sites. And so our 6 study sites are Intermountain Health, Lehigh Valley Health Network, the Phoenix VA, Scan Insurance, Stanford Healthcare, and Humana. Humana is the 3rd largest payer, insurance payer in the United States. And this whole study is conducted online, which is exciting because we are trying to make this type of pain care accessible to people no matter where they are. This is a home-based pain care study, and we hope to show that we can collect the evidence to show for whom which treatment works best. because, some people may need the longer course treatment. That's part of what we're studying. For whom does which treatment work best? And we're also looking at some of these subgroups of individuals. So there are a lot of different principal investigators that are studying empowered relief in different patient populations, in different clinical contexts and settings. This just gives you an idea of who's funding the empowered relief research, who's conducting those studies, and what they are focusing on. So we have quite a range of active research right now. We are funded by the National Institute on Drug Abuse to conduct a digital study of empowered relief. So we have taken the empowered relief intervention, which is normally delivered by a certified instructor over a Zoom platform. So it's a live class, but we have created a video version of that, tailored it to people who specifically have opioid use disorder or opioid misuse. And we also integrate in daily text supports, and there is the binaural app. This study opens next month. So if you know people who have chronic pain of any type and may have opioid use disorder, we would love for them to join us in the mobile relief study. This will be open for a couple of years, and this is a national study. So anybody, you can be, it's really untethered from medical care. You can be anywhere in the United States. It doesn't matter whether you have a physician or not. We'd love to enroll those individuals in the study. One of the most popular questions I get asked, do you have a version of empowered relief for kiddos? And this is in development as we speak, developing an adaptation for youth with chronic pain. This is being led by Dr. Laura Simons and Dr. Lauren Harrison at Stanford, and we hope to have data to share with the world later this year. Okay, so in my last bit of time, I just want to tell you how we've been applying empowered relief to help people undergoing surgery. And so people who have facial pain can kind of straddle two different buckets, because you're living with chronic pain, but then there can be surgeries that you receive to address the chronic pain, and then there's that acute surgical pain management as well. So recognizing that people undergoing surgery, attending classes, even Zoom classes can be inconvenient for a variety of reasons. We created a digital version of empowered relief that's tailored just to people undergoing surgery. So this is on demand, meaning people can get it on an iPad or on their phone or on a computer before or after surgery. The early version of this was called My Surgical Success, but it's essentially empowered relief that's tailored to people who are going to have surgery or who have had surgery. And we first studied this in women undergoing surgery for breast cancer. We randomized women either to a digital health education control that involved no skills, or they received the My Surgical Success digital intervention. And then we followed this cohort of women after surgery to see if the pain relief skills intervention would benefit them after surgery. And so we have 68 women, 36 who received the skills-based video intervention, and 32 who received the control intervention. We were really interested in the 2-week window of time right after breast cancer surgery, when women are most likely to be taking prescribed opioids for pain relief. And what we found was the women who engaged in My Surgical Success required a week less opioid medication for pain management. So this was both exciting and significant, because we weren't telling women to take less medication. This was a natural consequence of them having engaged with the intervention, learning the information. So that gave us a really nice signal. we did our next study in people who undergoing orthopedic trauma surgery at Stanford Hospital. This is a study led by Dr. Mesa Ziadny and Dr. Michael Gardner. He's the chief of orthopedic trauma surgery at Stanford. And we enrolled people undergoing who just had orthopedic trauma surgery post-op day 1, 2, or 3. So this is a population where they're going in for a fracture repair. Often it's an accident that somebody has had, and there's an emergent need for the surgery. They get the surgery right away. And then we gave people an iPad right after the surgery in the hospital while they're recovering. And same setup where they either were assigned to the digital health education control, or they got the My Surgical Success, which is the empowered relief tailored to people undergoing surgery. And so what we found was the following. Now, if you look at this graph here, you'll see that My Surgical Success is the blue line on the bottom, and the health education control is the red line on top. And a natural consequence of surgical recovery is that on average, everybody is going to be improving over time. And that was true here too. You know, you see the people even in the control, they're improving over time. But what we see is a nice separation where people who got My Surgical Success had significantly greater reductions in pain intensity after their surgery and all the way to 3 months later. This is a really important finding. Orthopedic trauma surgery, this population has a lot of pain for many months after their surgery. And it's often moderate to severe pain. So, you know, if we can give people something low burden, low cost, non-pharmacologic, that's going to help people have greater comfort as they recover from surgery, that's a huge win. Now, they still may need pain medication, you know, so it's not either or. We are inviting an integrated conceptualization of treating pain. So this type of approach that I'm talking about, empowered relief or My Surgical Success, these work alongside surgeries, medications, etc. And we are showing that we can help medical treatments we can help people gain better results from those medical treatments, excuse me, if they receive this behavioral approach as well. So we were excited about that. We have since enhanced, you know, I was just presenting data to you for the My Surgical Success version. What was really an old school version that I put together in 2015, excuse me, that was just me shooting video in my office. It was not slick. It was not really prime time. And so what we've done based on the success of all of our research is we invested in developing a really high quality version of this intervention. It's empowered relief for surgery, or surgical empowered relief. And it does have these brief video modules, but it also has enhanced features for the user experience so that you're kind of carried along in a journey where I will be delivering information by video, and then you immediately go into an exercise. You can complete surveys right there in the platform. You can complete your personalized plan as we go along in this journey. It's an 80-minute total journey. You receive this at home or anywhere you'd like. You download an audio for daily use, and accompanying it are daily text messages. Now, I'm just describing for you sort of conceptually what this is like. And what I'd like to do now, just in my last couple of minutes before we go to questions, is I want to play a video for you. This is a video trailer. It's less than 3 minutes, but it will give you a flavor, a taste of what this automated, on-demand digital treatment is like. And so I'm going to play the video for you for the surgical empowered relief. So hopefully the video plays okay, and we'll give it a go now. I was describing within the context of having medical conditions and these situations, your mindset impacts your health, all to my surgical success. We found that control.
She's a co-chair of the American Academy of Pain Medicine.
So this is installation. Hello, and welcome to your Empowered Relief course. Empowered Relief is mind-body medicine for health and healing after surgery or injury. Empowered Relief has been studied in 2 surgical studies. People who received Empowered Relief reported less pain for up to 3 months after surgery. This is the purpose of Empowered Relief. Okay, let's start your journey to Empowered Relief. But do you know how deeply connected pain and stress are? Let's explore this connection through a story. As your brain registers pain, it triggers, and the response to pain is similar to its stress response. Being unable to escape your pain can be very distressing. Recovery mode requires that we need to learn new ways to calm the nervous system. You'll have greater comfort while your body recovers. We'll talk about how you can apply this information and learn new skills to recover more quickly from surgery or injury. You know that pain is stressful. Being unable to escape your pain can be very distressing. It's the first step to empowered relief. This program includes a special calming audio to binaural audio. It has subtle tones. The sound waves work directly on your brain. In a good way. Follow along with me and let's try it together. Rate how much stress you're feeling right now. Let's begin by taking a brief pain survey. Now, I'd like you to rate your level of tension that you feel. You're going to learn skills and tools to help keep your pain and distress low. The Empowered Relief program helps you develop supportive thought patterns so you feel better and have a smoother recovery. This is your central nervous truth. This is the formula. This is important. This is Empowered Relief. Okay, great. Well, hopefully that just gives you a little bit of a flavor to begin thinking about how we can craft these digital interventions, these brief, Zoom delivered interventions as well, to provide the information that people need to understand how they can best regulate what's happening in the central nervous system, so that literally we're empowering people to have best control over their own pain, their own distress, not to the exclusion of medical treatments, but this is an integral part of comprehensive pain care. So before we go to questions, I just want to summarize here, broad integration of behavioral pain treatment is possible with some of these brief and accessible treatments. We see that they can have lasting reductions for pain and broad symptomatology for chronic pain and also surgical recovery. And we should be offering everybody access to these treatments for optimized outcomes, whether it's for ongoing pain or surgical pain. So with that, I just want to thank you all for your time and attention, for allowing me to present to you today some of the work that I'm really excited about, and I would be delighted to answer any questions you have.
Excellent. Thank you, Dr. Darnell. That was really amazing. Thanks for sharing all of that with you. We do have quite a few questions, so I want to get to a few of them that we have allow time for. Facial pain is just incredibly painful. So there's a couple questions about how this model would work with very brief pain moments that people with typical facial pain or typical trigeminal neuralgia experience. Yeah. And then, do you have any statistics or numbers associated with facial pain patients?
Yeah, great question. So, this general approach, the behavioral approach to pain management, is applicable to everybody, regardless of the type of pain that a person has, because what we're doing is we're literally targeting central nervous system processing. And so gaining better control over how our central nervous system is responding and the level of distress that we feel is universally applicable for facial pain. And when you're talking about, maybe the episodes where pain is at its most severe, one of the things to keep in mind, and this is my recommendation, and when I'm working with people, learn the information and start applying the skills, enacting the skills regularly. Begin when you're feeling relatively comfortable, or when, for you, your pain is on the lower end of the spectrum. That allows us to begin gaining some confidence and comfort with the skills outside of the most extreme circumstances. So it's sort of like practicing in an easier environment. And then we start those that can start to become second nature. What that will also do is we're sort of learning to down regulate our basal level of tension and stress. And so that's just beneficial in the day-to-day. But then also when those pain flares come, if we have that skill set, if we've learned that and feel comfortable with it, we're more likely to be able to apply it in that circumstance. So sometimes people will want to wait until pain is really severe to try these types of skills. And I guess my overall message is, paradoxically, engage with this information and use these skills when you're in the more comfortable areas, because that'll help you learn it and practice it and become better at enacting some of these skills and behaviors. And then you'll have greater comfort applying those later on. To the second part of the question about data on facial pain, I mean, to be honest, there's not great data looking at behavioral interventions in isolation for migraine, pelvic pain, facial pain. We've had a problem where through the National Institutes of Health, a lot of the funding has focused on back pain. Mm-hmm. And some of that really driven by this concept and science that we need to have, back pain's the most common condition, and also, having homogeneous samples. But we're getting away from that now. And so, for instance, in this PCORI study that I mentioned, the progress study, we're enrolling people with all types of pain. I would love to get a nice, meaningful cohort of people with facial pain in the progress study so that we can get some of that evidence that speaks, very directly to how well these treatments work in facial pain, and also whether one approach is better than the other for people with facial pain. Absolutely. Great questions. Absolutely. Thank you.
There's a couple questions about how to access this information. So is it available to people who are not connected with the 6 centers that are sponsoring the current research project?
Yes, it is. So you can access Empowered Relief a couple of different ways. It's embedded into healthcare systems. So I mentioned that there's 800 certified clinicians. The vast majority of those are in the United States, although there's many international clinicians as well. If you go to our website, you can actually just Google Empowered Relief and the website will come up, but it's empoweredrelief.stanford.edu. When you land on that website, it's really primarily for clinicians who want to learn the protocol to become certified. But you'll see that there's tabs, and there is a tab there for patients or find a provider. You can click that tab, and by country, by state, by area, you can look and see if there is a certified empowered relief instructor in your area. If you're part of a healthcare network or organization, you can ask them if empowered relief is part of the network or part of the healthcare organization. But there are several instructors who offer national, access online nationally. So wherever you live, you can go online and see about availability. So I just want to highlight one instructor. His name is Kyle Davis, and he's listed under Idaho. So you'll find him under Idaho, but when you click on his website, what you'll find is that he's offering free classes to anyone in the United States and possibly internationally. So at no cost, online, and you can get access to it. So he's someone that I always mention. He has several offerings, but you can kind of peruse the website and see who's offering national classes. I just know that Dr. Davis is, so accessible to you that way.
Excellent. We are coming pretty close to the end of our time. So this will probably be our last question, but we do have really a lot of them were about access to the study. So that covers a lot of what we talked about or what the questions are. But a question talking about the collaboration, I guess, of medicine and empowered relief together and the use of those together. There's a patient that's been on opioids for 10 years because of back pain, actually, and is wondering how these two, how would it keep her from being bedridden without the opioids by utilizing this empowered relief?
Yeah, that's a really great question. And one of a whole other study, which I didn't talk about today, we're running one of the largest prescription opioid tapering studies in the United States. I mean, really, really in the world. It's called the Empower study, not to be confused with empowered relief. But what we're testing, where everybody is undergoing a patient-centered prescription opioid tapering program, and then we are testing the additional benefit of some of these behavioral approaches and helping people reduce their opioid doses and reduce pain intensity over time. I think, a couple of key messages. One is that how opioid doses are reduced matters greatly. So if there is a poor taper, if the taper is implemented too quickly or under the wrong circumstances, there's no behavioral treatment that's going to overcome that. So foundationally, our methods, we really put forward a patient-centered opioid reduction approach that is very slow, that is collaborative with patients to help them feel and be in control throughout the taper. I can send lots of publications on that. Just email me. I'd be delighted to do that. But that's bedrock. So how the opioids are reduced really does matter. But what we're seeing is that if you reduce opioids the right way in partnership with patients, that they often do not have increases in pain. Pain either remains stable or it improves. This is an important message, but again, it's predicated on right methodology. And then something like empowered relief can absolutely support people in an opioid reduction program. But I just can't underscore enough that medical part of how the doses are reduced deeply, deeply matters. And once we have that in place, we want to integrate in something like empowered relief so people have the skills and the tools to support themselves through that opioid reduction.
Excellent.
Thank you. Great questions.
Well, I have one more, and I want to tell attendees, if you want to, we are within our little 5-minute break here. So if you want to navigate back to the agenda, Dr. Liedtke's presentation on medical assistance with trigeminal neuralgia is going to start at 1:10 Pacific, so 1 Eastern. But I did want to ask one other question just about cortisol, which is associated with stress and the harmful effects of cortisol. And does empowered relief help reduce that or keep that at least at a maintenance level where it's not causing difficulties with insulin and other issues in the body?
Oh, that's a fabulous question. And you know what we're analyzing right now, it's related to that, but it's not exactly that. We're looking at pro-inflammatory cytokines and whether engaging with empowered relief keeps overall inflammation lower as a consequence of people engaging with the skills. The cortisol would be one element of that, of course. What we are seeing is now the data that we have is really patient-reported symptom data, that people are reporting that they're less stressed, their pain is lower, they're sleeping better. So we have all of those endpoint suggestions that biochemistry is being favorably altered, but I don't have cortisol data to provide to you. But I have to tell you, I would love to do that study because it would be really powerful to demonstrate that and for people to have really to have that foundational understanding for how these treatments impact neurobiology, neurochemistry, and overall health.
Excellent. Well, thank you so much. This was a fantastic presentation. We really appreciate it. Attendees, as I said, go ahead and navigate back to your agenda to choose your next presentation. Dr. Liedtke will be talking about medical treatment for TN and neuropathic facial pain at 1 o'clock, 10 o'clock Pacific. So again, thank you, Dr. Darnell. Such a great presentation.
Thank you so much.